Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
Welcome back, everyone. Another week, another episode of the Research Works podcast. Hi, Dana. How are you?
Hello, Ash. I'm really good. I'm very excited today, as you can probably tell in my voice.
We always get a little excited.
Don't we? When we have someone in the studio, what a privilege. A dear friend returning back from the first season, I think, when we didn't even have a studio back then.
Rookies.
Thanks for trusting us back then.
And thanks for coming back.
Welcome, Gareth Baynam.
Hey guys, really great to be here again. You know you're getting older when you remember the originals. So thanks for having me back. Hopefully I can remember some of the words too from this song.
It's so good. It's good to have you here, Gareth. And we were just reminiscing. The last time that we caught up, we were in a lecture studio and we were just panicking someone would open the front door.
Yes.
It was hard work, wasn't it? Yeah, it's nice having a dedicated space.
And everyone here knows what's going on.
Yeah. So it's really good. Well, Professor Gareth Baynam is the Medical Director of Rare Care at Perth Children's Hospital, and we have a lot of questions, a lot of things to talk about today.
We sure do.
Yeah.
So for our listeners, we'll do our formal introduction of Gareth before we get into the fun bits. But Professor Gareth Baynam is a globally recognised clinical geneticist, researcher and advocate for rare diseases. He's the director of the Rare Care Centre at Perth Children's Hospital and the head of the Western Australian Register of Developmental Anomalies. With a career dedicated to improving the diagnosis, management and care of individuals with rare and genetic conditions, he's been at the forefront of integrating cutting-edge technologies such as genomics, artificial intelligence and precision medicine into healthcare. Professor Baynam is also a leader in Indigenous health initiatives, championing equitable access to rare disease diagnostics and treatment. Through his work with organisations such as the Global Commission to End the Diagnostic Odyssey for Children with a Rare Disease and the European Rare Diseases Research Alliance, or ERDERA, he continues to drive global collaborations and innovations that aim to transform rare disease care.
That was great.
Thanks.
On both levels.
Jeez,
Very impressive work.
Yeah.
I don't think it's me.
So funny when you see all the things that make up your day-to-day distilled down into a really impressive bio like that. You must think, gosh, no wonder I'm busy.
Listen, I'm so lucky. I just work with awesome people.
Yeah.
We've got the best teams and it's just so easy. You just try your best to support them and they guide you and you listen to what the families tell you that they need and you just try and help. And when you've got such awesome people around you, it's a real privilege.
Yeah.
And having the right people in the team always makes a difference.
Yeah.
Absolutely.
Right?
100%.
That's how big stuff happens is when there's cohesion in the team.
And collaboration.
And there's always going to be, someone that needs to lead it and have people follow a vision and a direction. That's what you do. But everyone within that team is so integral to making the vision come true. And it's fun.
For sure.
Yeah, I love it. I love it.
So, Gareth, that's the formal getting to know you part, but we obviously like to do an informal getting to know you as well, and we do that through our icebreaker question. Today's a tricky one. And it probably requires a little bit of reflection. What's the most ridiculous thing you've ever spent money on? I'll preface this by saying basically any outfit I bought in the early 2000s falls under this category. But
Look, I went through my drawers recently to try and see if I could throw stuff out, and I still kept a lot of stuff from that time. I don't know why.
Well, obviously they weren't ridiculous purchases.
Oh, look, I took them out and there's no reason why I should have kept them. And if I gave them away, I don't know if anyone would want to use them. So I think that's a good one. Do you want to go first, Gareth, or do you want...
Listen, anyone who knows me knows that I'm a bit of... Some people might describe me in various ways, but conservative with my money.
Okay, so we're really pushing you here.
I think I've some ridiculous things bought for me.
I
don't watch a lot of TV, and one of my family members who bought me a streaming service some time ago. We won't name names because you might want to be sponsored by them one day. And presented this proudly to me for my birthday, and I thought, okay. Clearly, that's for you.
I was going to say, is it one of those veiled
gifts? And I hope you enjoy it.
Yeah. Did they ask you for the login details?
Right. I love that. I love those gifts that you kind of go, you give to somebody like, but I will like this too. And they probably knew that if you don't watch TV anyway.
For sure.
That is funny. Well, ridiculous. There are a few things that do come to mind. And the more I think about it, the more ridiculous they become. So one was quite recently done. And it's really embarrassing as well. So I'll share it because I think it's useful for people to know that I'm really human too and I've made these big mistakes, right?
Safe space.
So look, I saw this sale online for some shoes and the shoes looked great. And the deal didn't look that great. Like it looked possible and plausible. Anyway, I went ahead, I bought it. I used Google Pay for safety because I was like, okay, I don't want to be one of those people that gets ripped off. And I submitted everything. And after I submitted it to buy these shoes, that seemed really good at the time, I then sat there and went, oh my goodness, I just don't think this feels legit. I just had a bad feeling. So I called the bank straight away. Now, first of all, I admitted it to my husband and said, I think I've done something. And he's like, you've got to call them straight away. And he's like, what's the website? What's the address? And I'm like, oh, you're asking all the questions and all the things I should have done beforehand. Yeah. Called the bank. The lady was then very concerned for me. She goes, look, I'm just going to cancel your credit card. And I'm like, okay. Okay, go ahead and do it. And she's like, look, don't worry, these things happen to people all the time. And it didn't look like it was a complete scam. I didn't get my details and I got my new credit card, but I did get the delivery and they looked like the shoes I bought, but also not really.
Oh, okay.
And it was more one of those resale kind of things. Yeah, that's right. I was like, oh, wow, these are really cheap shoes and, really silly. So look, I fell for it. It was a scam, but not a scam. Yeah. I still got a product. I did the right thing and I followed it up and I made sure I got everything changed. It didn't help that someone did try to, use our previous credit card under something else. There was some dodgy activities, so we canceled it anyway.
So you felt validated.
We had to change our details twice in 2 weeks. So that wasn't really fun because everything's linked to your credit card now. But it was really ridiculous and I just shouldn't have done it. But the problem was I knew it after I purchased it and within seconds.
And you probably knew it kind of while you were purchasing. You probably had a gut feeling.
Yeah, and it wasn't until afterwards. I just remember the sweats and like, I don't think so. So look, we didn't get scammed any money, but I got a product that didn't look like the product.
Okay.
And that was ridiculous. So there you go. That's a little bit embarrassing as well. But it hopefully helps people to know to follow your instinct and make sure it's got a proper address. And everything else looked legit. That was ridiculous. What about yours?
Sorry to hear that.
Otherwise, I'm very careful with my money. I don't really spend.
Unfortunately, both legitimate and ridiculous.
Oh, okay.
So I used to do a lot of, when my kids were up, would wake up quite a lot through the night. Because I was sitting up with them, I would do a lot of online shopping. So things would arrive at my house that I had no recollection of purchasing, but there were these, amazing next day deliveries. And I'm like, oh, that's nice. I wonder when I ordered that. Oh, no, I don't remember that. Okay. But one of the things and I thought I was trying to do a nice thing because my husband rides his bike to work every day. And in winter when it rains, your shoes get really wet and it's hard to dry them. I'd sit them in front of the heater every night to get them dry so we could ride the next day in dry shoes.
Oh, so
and
nice.
So my midnight scrolling on this website that shall remain nameless, I saw these things that were what I thought were shoe warmers. So they looked like little heaters that would go in your shoes and instead of the heater just like blasting the front of them, they would go in the shoes and they looked really efficient and like they would definitely work based on the photos. So I ordered them. I thought, that's a really nice thing. He'll be really excited about that.
Is that the one where you put the hairdryer in and there's like tubing that goes into each shoe?
That's what I thought they were.
Right, okay.
But then
I've looked at that.
Actually. But then they showed up. They showed up, Gareth. Okay, I'm feeling vindicated here. But then they showed up and it was just they were bean bags, but they were bean bags shaped like the inside of your shoe. So all they did, you just put them in the shoe and then you just left them. Oh. And that was it. And so I thought, okay, well, they looks legit. I'm going to put them in. Done. And then the next morning he's like, oh, my shoes are really wet. Oh, okay.
No.
Oh, that was a lot of effort. And I was trying to do a nice thing and it didn't. It just turned out ridiculous. So now I couldn't bring myself to throw them out. So every time I open the cupboard, I just see them staring at me and I laugh at them and then I close the cupboard door and carry on with my life.
So FYI to everyone, that's not legit. It doesn't work.
Don't do that.
Don't do
get
it.
the ones that Gareth was talking about that you know, there's a hairdryer system, actual heating system. They're not beanbags.
Okay.
Yep.
Good to know.
Yeah. There you go. Public service announcement.
I feel like we've both done that then. Confessions.
Buyer beware.
Buyer beware indeed.
Yeah.
Well, let's go into something that's probably much more useful.
Let's do that.
Should we do that?
Yeah.
Yeah, sounds good.
Yes. So, Gareth, rare diseases affect millions of people and families globally, but we find them to be often still underrepresented in mainstream healthcare discussions. So can we start off today with, I suppose, a bit of an update from you around some of the most significant developments in rare disease research over the last year or so?
Absolutely. It's an amazing time. It's truly a time of sort of conversion and inflection.
Wow.
And there's more than 300 million people on our planet that live with a rare disease.
Wow.
It's a staggering number.
Yeah.
And you think of just their nuclear family, that's suddenly 1 billion people. It's just an enormous number.
Yeah.
And so given the severity of these conditions, given they often affect multiple parts of the body, given they're lifelong, given the great majority of them start in childhood, it's no surprising that we now know that they're the single biggest cost in the health system.
Wow.
They dwarf everything else.
Wow.
And so if we look at inpatient costs across the entirety of the USA, 2/3 of inpatient spend, $2 out of $3 spent in paediatric inpatient care is on rare disease.
Wow.
Wow.
And it's a very small problem in adults because it's only $1 out of $2. It's only 50%.
Yeah.
So of course, I'm being completely facetious, but these numbers are just staggering. They are absolutely dumbfounding and staggering, and they've been duplicated now in different jurisdictions. They fit with data we have here in Western Australia. The numbers are now undeniable. I mean, you can't argue the numbers anymore. The change that needs to happen is an emotional acceptance of those numbers.
Right.
Because if you're like me and you're old and you've grown up with decades of these are the big things, and then someone comes along and says, well, yeah, those things are big and they're huge and they're horrible and they're nasty and they're massive global problems, but guess what? Rare disease is bigger than all of them combined.
Wow.
It's cognitively so dissonant.
Yeah,
and
you're
then,
right.
It's just like, but how could that be?
Yeah.
And then I guess the other bit that often happens is like, have I been sleeping at the wheel?
Yeah.
How could I not know about this?
Yeah.
How did I miss this? Am I incompetent?
Yeah.
But it's not. It's that, nobody really knew this true magnitude. This is new data, right? And so no one's missed anything. No one's fallen asleep on it. It's just been hidden.
Wow.
It's been invisible. It's been completely invisible. I think about rare disease and I think of the one word that comes to mind. It's invisible.
Yeah.
And now we're just getting this increasing visibility through all sorts of different avenues with the new diagnostics surfacing up the need, the new coding and ontologies to describe diseases and find them with all sorts of ways, existing ways, artificial intelligence, whatever you like. And the international visibility, we had the United Nations resolution on rare disease now a few years ago. It's looking like in May, WHO will adopt a resolution on rare disease. The World Economic Forum now has a rare disease group as part of the the World Economic Forum.
Okay.
And so all these big global bodies have now really got it.
Yes.
Yep.
Yes.
And said, look, this is a domain, just like other domains, be it cardiovascular disease, cancer, whatever. And so, it's as a domain, we need to be thinking about specific and targeted things across the whole life experience of what it is to live with a rare disease. So I think that is just creating a step change in everything to do with rare disease, including rare disease research. And I think, that data, that evidence, that advocacy, that political buy-in, the policies and frameworks and the legislations that result from that are what's driving this enormous change. And really where that's all come from is the rare disease community itself. Because they were invisible, because they were silent, because they weren't heard, they had to aggregate themselves and really drive the whole change, locally and globally. And so it's one area of medicine where the community has just led and leads the way because it's had to. And so, it's this kind of inbuilt community leadership, co-design, co-implementation, and all these co-words, right? And
collaboration.
So, collaboration is another great one, right? And so, it's just inherent. It's inherent in the domain. And I think, some of the biggest changes that we are seeing are really about the shifting focus to models of care coordination, clinical pathways, and the research and evidence around those. Because all the technological changes are marvellous. They really are, genomics, artificial intelligence, various imaging technologies, all those things which are really cool and really impactful and scaling and those sorts of things. But if you don't have the models of care and you don't have the pathways, you don't get the impact.
That's true.
And so what are the best pathways and what are the best models of care? Because if you think about it this way. Okay, so if you employ some new fantastic genomic or other omic technology and you get a diagnosis for a rare disease, now you've got all this power from that diagnosis. You can remove the uncertainty, you can talk about the risks for other family members, the options around that, the specific treatments, it might be drug repurposing, it might be mental health supports, it might be connection to people in similar situations, access to clinical trials. There's enormous power inherent in that. But at the moment, mostly we just bury it, right? So we make a diagnosis and we don't have the systems, the pathways to actually, unlock the power of that.
Wow,
so
that's a great way to
we
say it.
surface this massive power and then immediately dig a great big hole and bury it and put a mound of dirt over it. And so for me, the biggest step change is unlocking the power of those things through models of care and care pathways, because otherwise it's a little bit like another trauma. Here's an opportunity, and bang, we've got nowhere to go. So I think the biggest changes are really in that sort of access, the systems approaches to that and the individual approaches to that. So some of the systems approaches to that is you've got to track rare disease better in your data sets because the existing coding systems like ICD-10 are just woeful for rare disease. Only have a code for 3.5% of rare disease. So 96.5% just gets buried. And if we know this is the biggest cost in our health system, and we now know that, you're not tracking the biggest cost in your system. What business could operate without tracking the biggest cost in its system? None, you'd go broke. And so what the other fundamental thing to this is this is not just human rights, because it is fundamentally about human rights. It's also about sustainability. Unless and until we better address rare diseases, we will not have sustainable healthcare. And this is a global issue. It's not just a local issue, and it's particularly with the demographic transitions that are going on around the world. And so we are seeing the legislations, the policies, the awakening. Particularly, I guess, in low and middle income countries in particular, have gone, we see what's happening.
Right.
We can't wait for that. We can take some learnings from what's happening in these other places. We can probably leapfrog. And there's some opportunities here. And guess what? We're really innovative in LMIC because we've had to be. So we've got some really cool things that can really help you guys in high-income countries. And so, that I think is also really playing out now. So that's really a
What are some examples of that?
Watch.
That sounds so fascinating to me.
Think about things like sharing data or data infrastructures or those sorts of things. In high-income countries, the amount of barriers to those things, institutionally and otherwise, are
of course, very siloed.
Very siloed, extraordinary. if you're essentially starting from scratch
Uh-huh.
and you're assembling the tools to get the job done,
You can build that into what.
yeah, absolutely.
okay.
So
Yeah,
you can
that's
be
a great
far
example.
more agile, far faster. And the other thing is that in LMIC in remote areas, again, it's more the community itself that builds the solutions.
Okay, yeah.
And so that means they're directly aligned to what the community needs
There's no
Yeah.
bureaucracy there, is there?
and wants.
Yeah,
So
okay.
they're aligned to the unmet
Okay.
need
Yeah.
and then what the community wants. So I think we're seeing that paradigm playing out a lot. And then I think the other thing you're seeing is more and more entree of the big sort of data companies and those sorts of things into the rare disease space. Because these companies, fundamentally, they want to be providing services for the healthcare industry.
Yeah.
And so what better entry point?
Wow. Interesting, yeah.
So, I think, but for me, it comes back to models of care. It comes back to care coordination. And there's really been a dearth of research in care coordination, relatively generally across medicine, but specifically in rare disease.
Yeah.
And I think the really big step changes in the cross-sector approach to that care coordination. So how do you coordinate journeys across all the sectors, not just health?
Yeah.
So 16% of well-being is attributable directly to clinical care.
Wow.
Yeah. So if we just focus on healthcare, we're going to be an 84% failure.
Yeah.
Right? And so that's not acceptable.
No, it's not.
That's just completely unacceptable.
Yeah.
And so, so that's these sort of ways of sort of cross-sector, or some people talk about interagency or intergovernmental working. They all fundamentally mean the same thing. How do you connect up the sectors for the best life possible, be they the health sector, the education sector, the employment sector, the disability sector, the community services sector, because that's when you'll get real improvements and sustainable improvements. So, and we've demonstrated that through the Rare Care Centre. We're a 5-to-1 return on investment through our model.
Wow.
That's right. Wow.
Yeah.
Every buck you spend on us, we give you back 5.
Yeah.
Right?
Yeah.
And that's through cross-sector care coordination. It's through connecting up the pieces and aligning them to the needs of the needs in the families.
Yeah. Gareth, can I ask you about, prior to places like the Rare Care Centre being established, how much of the how to phrase this, we talk about models of care and care coordination. How much of the struggle with that was around, how much are we fighting against this name of, or collective term of rare diseases? Like, is it easy for people to not disregard, but to kind of throw their hands up and say, oh, well, this is rare. We don't really know what we're doing here.
Oh, well, absolutely. This is rare. Why should we care?
Yeah.
And, this is one of the challenges, but the why maintaining that, because the word rare is what is fundamental to all the challenges. It doesn't matter which rare disease you have, right? Of the 10,000 different rare diseases you have, it's the rarity that unites them. It's the rarity of the individual disease which makes it difficult to diagnose. Find access to the specialist care. Get access to a clinical trial. All this, get access to mental health support, whatever. But what I increasingly talk about is, as soon as you hear the word rare, you should immediately think common. Okay. And so why I say that is collectively they're common.
Yes.
Right?
Yeah.
So, about 1 in 12 people has a rare disease. That's a lot of people.
Wow.
That's common.
Yeah,
right?
it is,
You think about the number of children that live with rare disease in their base, 63,000. That fills her up the stadium with kids. That's common. Right?
Yeah.
Okay.
It's a lot of kids,
And then it doesn't matter what rare disease you have, there are commonalities in the needs around diagnosis, access to care, care coordination, access to trials, mental health support, So the efficiencies of scale and the equity are around addressing those commonalities that cross-cut all the different rare diseases.
Yes.
Because 90% of the journeys are same across the different rare diseases. And then there's a really important 10% tweak that's relevant to that individual group of disorders or individual disorder. So that the more people come together and focus on the commonalities and have that shared approach, the greater impact we can make, the more efficient we can be with our resources, but also the easier the messaging is.
Sure.
Yeah.
Because it's like, okay, because one of the things that potentially scares off clinicians is, how can I possibly know about 10,000 different things?
Yeah.
I'm a rare disease guy. I don't know 10,000 rare diseases.
Yes.
And couldn't even list 10,000. You know what I mean?
Yeah,
and
yeah.
so but if it's about, well, no, it doesn't. Some of the rare diseases, guys. Here's the commonalities, and here's how you can help.
Yes.
Yeah. Okay.
Yeah.
You don't need to be scared of this. In fact, you're looking after these people all the time.
Yeah.
Right. Okay. Here's just a few messages and a few tools that'll enable you to do that better and make your lives a lot better as clinicians whilst you're helping your families, and recognizing that the families are very often the experts because they have had to be the experts in their condition, and so it's partnering with them around and acknowledging their expertise, but also not finding ways that they can also remove some of that burden of always having to be the expert.
Of course.
Because that's a burden.
Yeah, it is. It is.
And so
they also just want to be parent.
So as soon as you hear the word rare, just think common. And you've got it.
Yeah.
Right?
Okay.
Yeah.
Cumulative common, and think about the commonalities that cross-cut rare diseases.
Yeah. You talked about the tweaks, when we're talking about care, I think, whatever the percentage is, 10, 20% around a tweak. Is that where precision medicine comes in?
Yes. And, to be frank, whatever precision medicine is. I think we could probably spend, 5 days on this show.
I was going to ask you about that.
What is it?
What is precision medicine? Good question, I think. I tend to think more of a precision public health.
Yeah, okay.
And which for me is about how do you help the most and the most at need, using a combination of ancient and old ways and new ways.
Yeah.
That's my definition of precision public health. And then, you have to be precise in what you're doing. Family clinicians always are. That's would they like to be more precise and have the tools to be more precise?
We're treating randomly here.
100%, right?
Right.
So for me, that's a tools thing. How do we get better tools in people's hands to allow them to do these things better? So the tools might be, for instance, we know that rare disease are the biggest killer of kids. 6 in 10 deaths in childhood due to rare disease, and so extremely unfortunately, palliative care is a really common discussion, right?
Okay.
So how do we give people tools around those palliative care discussions? And how do we give the palliative care providers the tools about rare disease?
Yeah.
And we've done this also, for instance, with mental health. So one of the things we've done around mental health is work. A lot of the things that we do are just connecting up and connecting to existing pathways and empowering those pathways because that's really efficient and sustainable.
Yes.
And so one of the things we did was work with something called MindSpot GP, which is a federally funded counselling service for mental health and well-being. We know one was to sort of connect to those pathways through the clinic, but the other we then said, well, how about we train all the different counselling staff that work through MindSpot GP about rare disease?
Yeah.
And just to know the commonalities and the issues because that informs their counselling. And what that means is their services then become more precise and sustainable because they don't spend their first 2 appointments talking to the families about all the stuff about
trying to unpack the rare disease.
Trying to unpack the rare disease bit. And that means that the families don't have so much of the ripping off of the wound off the burn, the bandage off the burn, as they have to retell all their story. They're still going to have to tell aspects of their story.
Yeah.
But hopefully they have to tell less aspects and to someone that understands things a bit better.
Yeah.
So that then becomes a much more precise interaction for that family.
Yeah.
I love that because you often talk about precision medicine.
It's a bit of a black box, isn't it?
Yeah, you see lots of grant call out for precision medicine. I always read and go, that's an interesting thing. But I don't think people often think about precision medicine from a mental health counselling perspective, where I think it's always about, I don't know, you tend to think about big data and trying to get to that.
And the machine that goes bing.
Yeah, that's right. That's
the way you're talking about it, though.
And remember, these machines that go bing are pretty cool too.
Yeah,
and
of course. They all serve their
purpose. But let's not distract from the other ways
that's right.
that we can be precise in a very scalable, cost-efficient quite cheap way that will make massive impacts for people's lives.
Yeah,
Absolutely.
so the way that you're describing, to me, at least it sounds like, if you have a finite resource, say X number of sessions with a counsellor or something like that, you're really able to maximise the effect that those sessions have by, having that common language and understanding first.
Yeah.
Absolutely. And the common language is really important.
Yeah.
So, and I think one of the reasons that the Rare Care Centre works so well is you end up developing a common language, a common lexicon, a way of speaking between all these different sectors.
Yes.
Yeah. Because all the sectors are often saying exactly the same things, just with different words.
Yes, yeah. And it takes how many hours just to even realise we're on the same page.
And so having that all in one space and time means you can actually develop that up. And so that's enormously powerful because without language, we're nowhere, right? And we can't, this podcast wouldn't happen without language, right? So it really, those developing up the common language is really important.
What is the role of, we talk a lot about artificial intelligence and big data and healthcare. That's a big language that we talk about a lot of the time, isn't it? Isn't it? Yeah. Where are things at when it comes to, how does artificial intelligence help and how does big data help in this
artificial
space?
intelligence is actually really helpful.
Okay.
But it's probably most helpful, not where people think it's the most helpful.
Okay. Interesting.
So one of the things we ran a couple of years ago was creating a framework for the use of artificial intelligence for rare disease. Because we thought, okay, this artificial intelligence stuff, we've been doing artificial intelligence for rare disease for, 12, 15 years. And especially in the accelerations in generative AI and multimodal approaches and multi-agent approaches and all these sorts of things. It was like, well, we're going to need some sort of framework so that it's not just tech-driven, it's kind of needs-driven, and we've got some sort of strategy about how this does this across the lived experience. So that's what literally we did. So we worked together with international experts to create essentially a framework for the application of artificial intelligence to the entire life experience of people and families living with rare disease. Because often people, immediately people think about diagnostic support.
That's right.
Great use of AI.
Yeah.
And so, but I think where we're seeing the biggest changes are in administration. They're actually in reducing workloads for people by all those really annoying administrative tasks that really makes you want to leave your career. You're like, I love my job, but there's one thing, there's administrative work. And so it's actually that area we're seeing really big impacts from AI. How can we take some of those more mundane tasks and automate them? You still need the human in the loop and all those sorts of things, but you can take a 10-hour process and make it a half-an-hour process with those sorts of things. So that means that though you can use your clinical skill and nous and apply it in a precise way.
I love that.
Right?
Yeah. Freeing up that part of your brain to do that.
And you're starting from a new starting point.
That's right.
So that's right now the biggest impact of AI.
Beautiful.
Okay. And
like
probably the second biggest is actually in administrative processes in systems. Okay. So managing data within systems, or and even things like generating better coding. AI can do that, and better disease classifications and unlocking signals from data. AI can do that really well. And again, that then becomes new pathways because you're unlocking these signals. Oh, tap that to a pathway.
Yes.
Now we're really humming. And then there's and then there's the other things: diagnostic support, treatment support, those sorts of things. And I think one of the big changes we're seeing there are these kind of almost like distilled approaches where people are saying, there's all these, uber high-powered, take large language models as an example, LLMs out there, and based in the cloud, big compute costs, you can do cool things with them. But the reality is no health system can afford two things. One, health systems are, quite rightly, extremely risk averse.
Yes.
There's very good reasons for that. And so if you're suddenly saying, commercial thing in the cloud out there with even if people have very good technical solutions that exist for those, which they do, there's still a huge perceived
risk
of course. Issue there.
It feels like a big leap.
And then a procedural issue about actually engaging that. So that's a time thing, that's a cost thing, that's a trust thing, really. And then, okay, do I have the budget to run these things in an ongoing way?
Of course.
So what I think we're seeing a lot of is basically saying, here's the big whiz-bangery of these big models. Let's use them to train much smaller models that can run locally on your laptop.
Yeah.
Right?
Yeah.
You know, really no new compute.
Yeah.
Right?
It's
Okay.
not contributing to the other data that's out there.
And deploy that inside your system, because that's sustainable. And so I think it's figuring out how to sustainably integrate these technologies. And I think, again, this is probably where the LMIC is probably going to win in a way,
right.
because they're going to be super lean.
Yeah,
of course.
super lean.
Yeah. What do we actually need?
How do we actually do it?
That's right.
With
That's right.
very little money.
That's right. Yep.
And so I think it's this. How it's a deployment issue, and then there's a fit for purpose issue. So if you take an existing off the shelf large language model, it works kind of okay for it. It's not pretty good. Could be a lot better. So there's a bit of that tweaking around disease, about purpose specific approaches. So I think it's a super exciting time. And we just have to be really pragmatic and practical and thoughtful about how we implement this.
Yeah.
And it's true. I think one of the words I've learnt when we're using large language models and AI is that it can be subject to hallucinations.
Oh.
So it can, in terms of the information, so you still need to overview and guard it because in terms of where it's coming from, right? So we're not saying, just rely on it. I think that's where people often, their heads go down that path, but you still need to oversee.
Oh, absolutely. There's still the clinician in the loop. The clinical curation is absolutely fundamentally required. Now you can create essentially agents that play the roles of clinicians to do that, and there's also fancy ways of doing that as well. This is kind of an evolving thing.
Exciting.
But we just got to have a little bit of practicality around this.
Gareth, this is probably a hard question to answer because I'm sure there's many things that come to mind with this question, but are there any particular breakthroughs in rare disease research or therapies that you have been involved in or have come across that have really caught your attention and made you think, wow?
Oh, absolutely. Yes. I mean, purely from a therapy, if you use the word therapy, I mean drug, which that's what most people
True. They think about.
They think about it. It's not what I think about when someone says therapy. I think about the broad range of things you can do to help someone. But if you take the drug lens on a therapy, then I think there are some super exciting things. One is basically from the diagnostics, understanding what the cause of the disease and then untying the pathways a bit, you can use existing treatments better. So you can take drugs that are off the shelf, often very safe, often very cheap, and use them for a new use.
Oh, wow.
Wow.
That is exciting.
That's always
super
good.
exciting.
Yeah.
And you can take some drugs that are literally sitting on the shelf and not really doing much, and people say, don't have to ignore, or, I kind of bring them back.
Wow.
And so... and you can do that in two kind of ways. So you can do it what people call sort of off-label use. As a clinician, you just give it. Or you can do it as part of a repurposing trial. We can essentially do a clinical trial and repurpose, reuse an existing drug for another purpose. The fastest growing segment is the off-label. People are just doing it, right? Because the necessary rigor around a trial is high.
Yes, of course.
And the time that takes.
And if you've got a dying patient in front of you, you don't have time to do that. Right. So there's a moral imperative. And so I think that's sort of, if you like, off-label use. And
what's an example of that one?
I can give you an example. The very first time we used clinical exome sequencing in 2013 was to diagnose a particular rare condition in an Aboriginal family from a very remote part of WA. And it turned out that at that time, the gene that we found hadn't been associated with human disease. And so we had to do a bunch of things to prove that it was actually the cause, but anyway, that's another story. But that gene worked far too much, right? That was the problem. Basically, it killed the off switch on this gene, and it just ramped up. Right? It was causing chaos. Yeah. But we knew that there were drugs that switched that thing off.
Right. Okay.
They've been used for, transplant and immune conditions for, decades.
Wow. Wow.
All right.
Okay.
And they were cheap. They were
Yeah,
off the
yeah,
shelf.
okay.
They had good safety profiles.
Yeah.
Oh, it's perfect for here to treat
Right.
these kids' intractable seizures.
Yeah.
And
Okay.
because of this particular condition gave them an increased cancer risk. Oh, if we got a new cancer treatment for these kids, yeah, potentially.
Wow.
Yeah.
And so that's super powerful, right? And so I think that would be an example. And then
That's
we've
a
got
great example.
Yeah.
and then we've got other examples of where now we're literally making medicines for one person
Yeah.
or a few people.
Yeah.
Yeah.
It's targeted to their individual gene change.
Wow.
Yeah.
Mm-hmm.
And we're doing that in Perth.
Yeah.
And we're manufacturing these things in Perth.
Wow. Okay.
Right?
Incredible.
So I think that's and we've done to a certain point of that development.
Yeah.
Done probably about 6 in the last 4 to 6 months.
Wow. Okay.
And that's nowhere near the scale that we need.
Yeah. Sure.
But when you think that
wow.
the average development drug cycle is between sort of 10 and 20 years, it's a bit different.
Significant.
And so
Yeah,
I
that's
think these kind of
perspective.
individualised
Okay.
medicines, N of one therapies, sometimes you hear.
Yeah.
And people are really talking about this in other terms, like sort of essentially molecular transplants or molecular surgery, because these treatments don't fit under a standard trial paradigm. They're much more like surgery or transplants, right?
Yeah.
You don't say to a surgeon, hey, neurosurgeon, this kid's about to die. You need to do a clinical trial on the surgery that you're about to do for just this one child that you're going to do in a certain way.
Yeah.
Right? And so this is where medicine is heading with these therapies. So they can't be assessed under the standard clinical trials.
No, you wouldn't have the power to be able to do that.
That's right.
These
Yeah.
are treatments,
That's
right?
right.
These
Yeah.
are treatments.
Yeah.
And just like it's a surgical treatment in a domain that you de-risk by your clinical skill and all those sorts of things and certain sets of parameters.
Yeah.
But in the end, it's a highly personalised thing.
Absolutely.
In a severe unmet need. So it's that paradigm and creating the sort of the permissions and the regulations to actually enable that to happen.
Yeah, I was just thinking about that as you were talking. What are the ethical considerations around that? Is it do you kind of pivot in terms of study design to try and prove the efficacy of these treatments? How do you manage that? I imagine it's very different depending on the scenarios that you're faced with. But
you start with where the need is the highest.
Yeah,
right? And you learn from there.
Yeah,
and you build from there. This is the safest way and the most equitable way.
Yeah, sure.
To do this.
Yeah.
So if you've got a condition that uniformly kills children, and you've potentially got a life-changing treatment, and I'm not going to use the word cure because I think we have to be very careful about using the word cure.
Yeah.
Almost nothing I've come across in medicine is a cure.
It's a cure.
So I think you've got to be very careful about the use of that word. But of a dramatically life-transforming
Of course.
treatment.
Yeah.
Well, perhaps we should start there.
Yeah.
And then we'll learn from that.
Yeah.
And there's a kind of moral beauty in that too. And the moral beauty in that is that if you're like the most vulnerable and the sickest kids who have the most to gain will provide the way forward for all of us.
Yeah.
So these are gifts.
Yeah.
These are gifts from these children to all of us.
Yeah.
And so now we also have a moral imperative to return, to respect that gift and return benefit to them.
Yeah.
Okay?
Yeah.
And so I think there's a lot of humanity, and there's a lot of human rights around this, and as well as opportunity, and it's just for this kind of intergenerational virtuous cycles.
Yeah. And it sounds like, and I can see why one of the questions we asked when we first saw you today was, how's life? And it's busy because it's great. It's amazing because there's so many things happening in the space. I can see now. Like there's on so many fronts, and let alone the fact that you're developing these care pathways as well, which is so significant. So with all this new development that's happening right now, where can clinicians or families go if they want to know more about, rare disease or advocacy and get involved in that way? Because the fact is we have many children on our caseloads who have a rare disease. That's what we're saying, right? Yeah. So, what can we do or where can we go?
Okay, well, let's start with the world's biggest medical workforce.
Let's go. Yeah.
Nurses.
Yeah. Yeah.
Yeah, okay.
You talked about that
They're the
before, yeah.
world's biggest medical workforce.
Uh-huh.
And in many parts of the world, the only accessible workforce.
Very true.
Right?
Yeah.
So that's a great place to start. So when we were sort of putting together the Rare Care Centre, we were doing a lot of international engagements and scoping and meetings, and we met all these very sort of high-profile people from all these sorts of sectors, doctors and lawyers and pharmaceutical company heads, and all these people saying, "How am I going to do this?"
Yeah.
There was just like no nurses in the room in any of those discussions. I was like, but these are the people that are providing the care
across the world.
Yeah, and these are the people that are the intimate, closest contact for the family, for the families. And so, our centre is co-directed by myself and an amazing nurse, and a lady called Sue Baker, who's just incredible. And so Sue's brilliant idea was, we need to change this. We need to create a global nursing network.
Yeah.
So we pulled together some global leaders, we pulled together nurses from around the world, we funded all the LMIC nurses to represent their countries, we paid for them to come in and backfill their wages and all those sorts of things. Because we had to design this so that it would work for the world. And so any nurse out there, any nursing student, any midwife out there, any midwifery student, Google Global Nursing Network for Rare Disease, GNNRD.org.
Put that on our website.
Put that on the website. So that's a platform that connects nurses across around rare disease.
That is
because
awesome.
every nurse, every midwife looks after people with rare disease.
Yeah.
So every nurse and every midwife needs to know about rare disease. They don't need to know about the nth detail of every different rare disease, but again, it comes to those commonalities.
Yeah.
So we're now 60 countries in that network, and more than half are from low and middle income countries.
Wow, great.
Amazing.
And so there's an online community of practice, there's education materials, there's all sorts of things, right? And it's all free. It will always be free. We're committed. We're committed to that. And so just jump on, have a play, go and connect with other nurses around the world, and start having a yarn.
That's fantastic.
Yeah, it's really incredible.
Isn't it? And I love how, we always, in a lot of these podcasts, we talk a lot about, equity, because a lot of the work that we do often are developed in high-income countries. And then the question is, how do we translate this into other countries for equity? Yeah. I love that this is just the other way around, in the sense that we're learning so much. And it's the same, I think we've spoken about this before, the work I do in Malaysia and what you learn there. And you go, I learned the things I learned there, I then bring here, and we're just so much more efficient because you have to.
They're driven by necessity.
They really are, and you're creative.
So this podcast never goes out to anyone in the UWA medical faculty, does it? Because
we can't put any guarantees around that.
Because I learned more medicine in my elective in Malaysia than I did in my medical. Right. Because you just had to see lots of patients and think.
Really, and on the fly, and you're like, almost like MacGyver in a way. Things you can do.
Anyway, so I'm teasing you. Great thing. We love all the people that let us become medical students. And so then I think there's a couple of other areas that I'd really encourage people to check out. The Peak Advocacy Group for Rare Diseases in Australia, Rare Voices Australia. They're brilliant.
Yeah,
right? Hop on and have a look.
Yeah, great.
For the researchers out there, the International Rare Disease Research Consortium, ERDERA, which sounds terrible in every language except French. and so hop on. And,
would you like to try it in a French accent?
I would not. And so hop on and have a look at that. So that's a global multi-stakeholder consortium of funders, patient advocate organisations, governments, that represents $3 billion with a B per annum in committed funds to rare disease research.
Wow.
That's not that it all goes in a big pot and then we split up the pot. That's what each of these individual members, when they say what they're doing back home and come up with a dollar figure, and they add that up, and then we add them all together.
That's amazing.
Yeah, okay. Yep. And so this is a coordination function for the world around rare disease.
Yep.
And it operates through several mechanisms, including task forces, where it says, okay, this is a really critical issue. Stigma in rare disease, massive issue. Right, we need a global task force about that. Right, okay. So hang on, jump on there, have a look at it. Have a look at all the previous task forces and publications. Have a look at the current ones, and you'll get a really good sense of where the world is in rare disease and where it's going. And so the International Rare Disease Research Consortium, if you're a rare disease researcher, that's your number one protocol. Get on and have a look at that.
Okay.
We will put links to that. We'll put links to that. So, gosh, Gareth, we knew that this conversation was going to be a very exciting and rich conversation because of the space that you're in at the moment. We're going to have to make sure we touch base with you more often about all the developments that are happening, but really encourage everyone to look at those websites. We'll put them on our website, researchworks.net, because it's just so important. We are all working with people with rare disease, so we all need to understand more and follow along and understand what those care pathways are. Like I did not quite realise that dollar figure that you put on it in terms of the return on investment, which is what everyone's interested in. If you can do that better, that's a huge step in the right direction already. Yeah. So
for
huge.
Sure.
Gosh.
Gareth, I'm going to put you on the spot here.
Sure.
For our healthcare professionals and families who might be listening, what is the one key takeaway you would like them to leave with today regarding rare disease research and care?
Good question.
Think rare. Right. So if you're a clinician out there and you've got a child with, say, intellectual disability plus something else, or just severe intellectual disability, if you've got a child with multiple congenital abnormalities, multiple differences present at birth, hole in the heart, cleft palate, spina bifida, whatever. If you've got a child that's just got really crazy lab test results and you just can't explain them and you've repeated them and they're still crazy and whacked out, if you've got a child that has got something that you've only ever seen in adults before, think rare. There's probably an underlying rare disease. Okay. And then get some friends to help you. And so if you're a GP out there, say you're in WA, get on the WA Primary Health Alliance website. There's a really good sort of care plan, if you like, for GPs to think rare and then to figure how to go from there.
Wow, okay.
So check out the WA Primary Health Alliance for that. So it's called the Rare and Undiagnosed Disease Pathway, I think, something like that.
Put that on the website as well.
Put that on the website. So think rare.
Okay.
Think rare.
Great advice.
I think so.
Gareth, thank you.
Pleasure.
Thank you
so much.
I think we could talk to you all day,
I know,
but we
really
have to
could. He's got stuff to do.
He's a busy man, as you probably gathered.
Yeah, that's right. No, it's such a pleasure.
But it's always so inspiring to talk with someone who is so passionate about the work that they do and advocates as strongly as you and your team do. So thank you for spending some time today with us doing that.
Thanks, guys. It was fun.
Thank you. Yeah, that's why we're friends, I reckon.
I think so. Well, I know so.
So to all of our listeners, remember, researchworks.net. I will go through all of that and make sure there's links there for you so you've got it all in the one spot and you can find everything there. And have a really great week and we'll talk to you all again really soon. Thank you so much, everyone.
Thanks, Gareth.
Thank you. Bye.
Bye.